Nicole.
Thanks, Sabine. Thank you, everyone. It's such a pleasure to be here. So, Nicole and I decided to take sort of a different approach where instead of just diving straight into the presentation, we would have a bit of a chit chat and use that opportunity to share about our work, our research program, how we started collaborating together, the kind of work that we're doing at the moment, and perhaps even an open invitation for you to join that work for those who are interested. So, Nicole, I'm going to sort of hand the mic to you to ask you to kind of speak to everyone in the room about your program of research. And I have some of the trainees who work with me ask me, how did you find your way to start focusing on digital health equity? So perhaps share a bit of that journey with us.
Yes, thank you for your question, Ibukun, and also thank you for the invitation to be here. It's a pleasure to share some of my work, and I really hope that some others could join our collaboration because I really enjoy it. Yeah, it's an interesting question how I started looking into digital health inequities. And I think it started already in 2007 when the city of Amsterdam asked me to, in a large meeting, ask me, should we give children a laptop or a tablet? And then, my first response was, and it was in 2017, so way before COVID. So the topic of health, of digital inequality was not very high on the agendas. And then I said, I think we should ask this to children because I'm an adult and I don't know the answer. So and I was inspired also with my from my supervisor Christine Dedding, and that's how we started with a very small project, which at the end turned out to be my PhD research. And in my PhD research, I really tried to understand the perspectives and needs of citizens with a low socioeconomic position in the digitizing society. So it was a little bit broader and not really focused on health. And I think those citizens inspired me, and they learned me that, the digital inequality is not just an individual problem. We cannot expect that individuals keep investing in their digital skills, um, in their access to materials, if we don't design a digital society which is also accessible by those citizens. So we really shift our perspective on how we should view digital inequality. And then after my PhD, I moved to the Amsterdam University Medical Center, and there, I transferred also my research to the health context, and that's why I'm now really working hard on the digital health inequality, rather than only about digital inequality. But there are a lot of interrelations
Yeah.
between that. And Ibukun, how would you answer that question to your students?
Yeah, no, it's interesting that you mentioned how it was your PhD that was the gateway for you into digital health because it's
Mhm.
very similar to my story. So I trained as a medical doctor. I decided after my master's to go do a PhD, and as a clinician, my interest was on maternal, child, and reproductive health. And so I thought, if I have the opportunity to research anything related to access to quality care, particularly in low resource settings, that was good enough for me. And so when I got the Erasmus Mundus PhD fellowship, I came to the VU in Amsterdam, and we'll talk about that a bit later. And my supervisors had an interest to look at how digital technology could improve the quality of antenatal care in low resource settings. And so I said, well, my checklist was maternal and child health, low resource settings. Somebody has decided to add this layer of digital health. I'm up for the challenge, so let's figure it out. So that was literally my first foray into digital health, and the focus of my research was looking at clinical decision support systems and how could you use clinical decision support systems that were very automated, designed by a Dutch company, which was then translated into Ghana. How do you use that for task shifting to be able to provide care closer to home for community members who sometimes would have to walk or cycle 20 kilometers to get to the hospital? And so it was a very eye-opening experience for me because I could see that you could place technology in a new context, but if you're not very mindful of the ecosystem in which technology is placed, you're only going to cross more divides. So that's where the equity piece really stuck out for me. And I continued to chase that line of inquiry. I got involved in realist methodology because that was the core that I used for my PhD. And so I was able to sort of take a realist lens to understand digital health inequity for improving quality of care. So when I finished my PhD, I had the opportunity to move to the Institute of Tropical Medicine in Belgium, in Antwerp, and there we're focusing on health systems and policy research and health equity. It's like, okay, this is a nice combination. So it almost felt as if, as I was going along in my career, I was picking up different topic areas that intuitively may not have intersected at the time, but now looking back in perspective, I'm like, that made perfect sense. So I did health policy systems research intersecting with health equity. We did some urban health equity work as well. Moving to Canada, I think for the first 3 years I was in Canada, I was mostly focused on international monitoring, development, and evaluation work. But eventually, when I got my first scientist role, it was actually working with policymakers to be able to answer their questions regarding digital health. So, again, another connection to yours is your inquiry started from being in this room with policymakers who had a question. And I think that that's what I love the most about the work I do as an applied researcher, which is you're not pulling questions from the sky. I think as researchers, we tend to always have a lot of questions, but you're actually answering questions that policymakers or communities really want answers to. So that's sort of like a quick a quick overview of my journey. So I do a lot of policy applied work now, like the provincial Ministry of Health wanting to understand. We invested heavily on remote patient monitoring during the pandemic. Which of these innovations do we scale and spread? Which ones worked, which didn't work? I think one common theme in all my evaluations was sort of really seeing that nuance between who got to benefit from the technology and who didn't get to benefit. And so that's why I've built a big part of my research program around digital inequalities and artificial intelligence as well. So, yeah.
Yeah, super interesting.
Yeah. I wanted to go back to something you had said about
Mhm.
your PhD research and then the following work helping you see that the way in which digital inequality is conceptualized is not an individual problem. And I think that that was one thing that we both resonated on when we reconnected after many years is digital health inequality is not just about handing a laptop or a tablet and giving skills. So perhaps some time to just share a bit more and elaborate on how do you view digital health inequality in your work? Because it shapes the way you approach your research.
Yeah, I see digital health inequality really as a societal problem. So we need to look for solution in the policy landscape, in how technology is developed, how it is implemented, and how it is used in practice, rather than really focus on those individual barriers. And I think it's also always good to realize that digital inequality is not really about the other. It's also about us. I mean, people rarely grow old without limitation, but and also if you have an accident or you have long COVID, there are so many reasons why you cannot keep up with the very quick digitizing online world that we should not talk about the other, but we should talk about us ourselves and to see where we could design our digitizing society, more human and more inclusive for all different kinds of people. So that's for me. It's always important if I talk about digital health inequality. It's about us. It's not about the other, and it's about the societal problem and not individuals who need
Yeah.
to learn new skills or who need to buy a smartwatch, for example.
Yes. No, I completely agree. And,
Yeah.
to your point about your first research as part of the PhD was looking at digital inequalities at a societal level, and
Yeah.
then you went specifically into digital health. There are very clear overlaps, and I feel like one thing we need to switch is not just the fact that technology has been introduced into healthcare. I think it's that on a broader scale in society in general, we live in a digital world. So
Mhm.
communication is digitized, access to economic and financial services is digitized, access to education. I think that really blew up and came to light during COVID. Access to education is digitized. Our social connections are digitized. So it means that if on a general level, people were more included in other parts of society as opposed to healthcare, then you bring this digital, I would say digital bridge, quote and unquote, into the system, you create a wider gap. Also, because for many marginalized communities, healthcare is not always the priority until it's at a critical point. So I feel like if we solve for inequity at a societal level in general, we will, in some way, at least to 50%, solve for inequalities in healthcare. One of the papers that I had come across recently, and I think we spoke about this in our last meeting, was some work that came out of, I think it was the WHO regional office, where they did a scoping review about the digital determinants of health, or rather the health determinants that were shaping digital transformation at a societal level. And what was interesting is they highlighted about 127, almost 130 health determinants. And of these health determinants that are intersecting with digital transformation at a societal level, most of it were about the technology itself, but a big chunk of it was also about commercial and economic interest, which was like second ranking, as well as political determinants. And I found that very fascinating because when we talk about digital health equity, we really tend to focus on like clinicians and frontline staff, and we focus on like patient scheduling. But I love that paper because it really blew up the macro level and the unseen factors that are actually shaping what translates at the very micro level. So I wanted to segue from that and talk about, given how you take this very wide societal focus lens on understanding and conceptualizing digital health inequity, how does that influence the different disciplinary lenses that you draw from and the different methodologies that you use in your research?
Yeah, I think my PhD research was really started from participatory action research, so doing research with people instead of about people, and also um, really trying to understand their perspectives and needs and basing action on that needs and action. But now we also take a little bit. We take a more a system lens, so we combine system thinking with participatory action research to also involve the system in order to come up with solutions and also try to make changes in the system rather than only with the people on a very community-based level. But I think it's important to also have the participatory action research approach really central because yeah, I'm trained as a participatory action research and I don't want to do research without the people who are affected by this. So for me, that's really an important, really important.
Yep. I think that that's very clear from the fact that when you were asked that question about should we give children laptops or tablets, I think some researchers would just have said, from their own perspective, like, yeah, give them tablets or give them laptops. But you were like, hold on, let's go back and ask the children this question. Like, that's a very clear case that intuitively, almost like in your research DNA, you always co-design, you always ask the community question. For me, again, I also use participatory action research, systems thinking, complexity theory. I'm a very theory-driven thinker, which is probably obvious from my realist methodology leanings. But I think that that's the way I see the world. I think one thing that has also shaped my perspective is collaborating with researchers from multiple disciplines. Someone else that I often brain spar with is an anthropologist, and she uses STS theory to unpack how technologies are shaping care and caregiving at transnational levels, which is, it always blows my mind. I've often had to work with like AI engineers and data analysts to figure out like how are you building bias into systems. So I think that collaborative approach really expands a more macro level conceptualization of digital health inequality, but also a more macro level approach to addressing the problems that we're seeing reflected at the individual level. Okay, so we don't have a lot of time before you jump into your
No, it's all
presentation,
right.
but I thought that it would be interesting for the audience to kind of know how we started collaborating and
Yeah.
yeah.
Yeah, I think it was yeah, accidental. I mean, we proposed our research that were able to start a research project doing EF right, and of course we met at the VU when you were doing your PhD, and when I started my PhD, because I don't think we worked together for a long time at the VU. I think only a year or half a year or something like
Yeah.
that, and then yeah, that was a sort of spark when we started collaborating, and it was really interesting to see the overlap between our work, but also it was really interesting for me that at that point I felt, oh, there are not that many researchers working on this topic, or not in the Netherlands, and that's nowadays it's totally different. There are many more researchers working on this topic, which is really great and inspiring. But at that moment I felt, oh, I really need someone to really compare also the research in different settings, because
Mhm.
also how quick societies are digitizing is very different between countries. So I think I really like to see, yeah, when the digitizing, when the process is going a little bit slower, whether there is more space and time to think about
Yes.
inclusivity or not. So
Yeah.
yeah,
Yeah.
the comparison between countries I think is really interesting as
Yeah.
research.
And that's one of the things we're working on now. And before elaborating on that, I just wanted to just speak to the fact that, sometimes we connect with people either through our studies or through work or through a conference. LinkedIn is my literally my professional vibe. But what was interesting was even though I think it had been almost 5 years since I left the VU, it was the post that I think you or Christine had made about the funding that had been secured and the project that was going to start that caught my attention. And then I reached out to Christine. I'm like, wow, long time no hear from each other, but you are working in digital health inequity and I'm working in digital health inequity. It'll be nice to hear about your project. And then she's like, oh, Nicole is actually the one who's leading this work. So you guys connect. And we connected, probably going on almost 1.5, 2 years now. And we have since, like, every meeting, every opportunity, we've been able to say, okay, what are we working on? What are the new papers that have popped on your radar, shaped our perspectives around how we're thinking about this work together, which leads to the work that we currently decided to start doing. So just to share for everyone is we decided to do a comparative policy analysis on how different countries, so starting with the Netherlands and Canada, are conceptualizing and acting on digital health inequalities. So from a very policy level, and we're not only looking at health policy, we're looking at commercial policies, regulatory and governance, data sharing policies. Nicole has a PhD student who has done some work looking at that policy context within the Dutch environment. Nicole, maybe you want to shed a bit more light. I don't know if I missed any of the details on what we're working on.
No, yeah, we submitted a paper about that work, so I hope that it can be published quite soon. And yeah, what I really liked from that experience is that in policy we talk about health inequities, and in policy we talk about the digitalization of care, but we do not combine the policies about health inequities and digitalization of care. Well, I think the digitalization of care has a major influence on health inequities. So there is no link at all in those policies. So that stood out for me.
Yeah, and that's why we're now taking this. Okay, let's compare that to what is happening in Canada. Just going to open the floor to say, like, if anybody is interested and has an interest or ongoing work in this policy analysis or policy context regarding digital health inequities and you'd like to join us on this comparative journey. So we're kind of in the early phases of the work. Please reach out. We'll be happy to throw in a bit more countries in the in the work that we're doing so that it's more of a richer output. So the idea is to do the analysis and then write a paper that we can put out to the public. Okay. I think there's still a lot more we can talk about, but we have not enough time to get into your presentation. So I will hand it off to you, Nicole, to share your slides, and then we can hear a lot more about the project on doing e-health right and the systematic review that you conducted.
Yes. Um, do you see my screen now? The whole screen?
Yes, it's coming up.
Yeah.
Yeah,
Ah,
you're good. Presenter mode.
yeah. All right, perfect. Thank you so much. Yes, in the presentation, I would like to zoom in a little bit on the project Doing eHealth Right and how we started this project. Yeah, I think this visualization already visualize what we already talked about. It's the words are in Dutch, but I think the main message from this visualization, which is an outcome from my PhD, is that the focus is always on those people who are trying and struggling to get enter to the online world. Well, and that's visual, but we don't focus on how the digitized health system is built. So the ones who are behind the vent. But I think Ibukun and I talked already a lot about it. So that was really the starting point for us in doing eHealth right. And in the Netherlands, just a little bit the context. Digital technologies are really transforming our healthcare setting at the moment. And that is due to the COVID-19 pandemic, of course, when we were forced to do a lot of things online, but also the growing demand for healthcare due to emerging demographic challenges like aging or like migration. And in the Netherlands, there is also a high focus on patient autonomy and yeah, to increase patient autonomy, online tools are often the answer. But what is not really inside is the rising health inequalities. But that's also something what's a trend what's happening at the moment. So in the Netherlands, there are large health inequality, and it's really a persistent issue that's already there for a long time. And I think it's comparable to other countries. In 2023, the life expectancy for people with a low socioeconomic position compared to people with a high socioeconomic position was 6 years. And in perceived good health, it was even almost 15 years. So the trend of digitalization takes place at the same time while there are still large health inequalities. And it is interesting to see that those people who are affected the most by digital and by health inequalities are people with a low socioeconomic position. So those are the same people. And I won't get too much in detail about this, but there are selective and causal processes in health inequalities. And the interesting thing is that the online world adds an extra complex layer on this. So it has influence on the opportunities you have in your life circumstance and in your lifestyle. For example, um, yeah, the access to basic to essential services are online nowadays. Like Benny said, then you have to apply for a job and things like that. But if you don't have a computer at home, how do you apply? And then how do you get an answer? So it's really the digitizing world has really influence on your life circumstances. And it's not only about applying for a job, but also like Ibukun already shared, it's about a lot more things that are online nowadays and has really influence on your life circumstances. But it also adds a complex layer to your health more directly. For example, in the Netherlands, the online world is often not a choice anymore, but it is really something you have to do. This is a story of Hawa who tells that if she wants to make a doctor's appointment, she always goes to the GP, and then most of the time people ask, "Why are you here? You should do it online." People say to her, and of course, she needs a lot of encourage to ask that she can't make it the appointment online, and she's afraid to that she if she calls that she is not that you don't understand it well when the appointment is. So she really want to make it offline, but then people always tell her, yeah, why are you here? Well, you should. It's normal to do it online, and the fact that people feel like that it's normal to do the things online gives other people's a feeling that you don't matter anymore, and this can affect people's mental health directly. Like some sentences is always the same. I'm once again referred to in court, and then you tell you it's online. Just fill it out online. Then I need to call my brother again. So it's a continuous process um, of a feeling that you don't matter anymore. And I don't like it, but also when you call a company, then the first thing you hear on the phone is, do you know you can find out all our answers online? So it's not only the humans who will tell you that it's normal to do the things online. Also, when you call a company, you get an automatic voice. They say it's normal to do things online. You should do it online. This really affects people's mental health. And it also sometimes avoid people to access healthcare. Like the story of Sarah, who had to take a photo of her daughter's burn and send it by email to the urgent care center. And she had never done this before, and she felt really uncertain. Would the photo be clear enough for the doctor? Can the doctor accurately assess the severity of the burn? Um, would the care her daughter would receive be adequate? But also, who has access to the phone of the photo of her child? And yeah, her doubts and concern, especially about the privacy of this intimate images, held her captive and avoided her sending the picture. So she didn't go to the doctor. She didn't send the picture, and she only used some care that she could provide herself. So it's really interesting to see that there is a sort of um, digital a cycle that um, where the online world really impacts your life circumstances and indirectly your health, but also really directly influence your health. And I think in the articles of Baum and Bayer, there is really they talk about the digital health vicious cycle, and it's really interesting to read these papers. Um, and the fact that people that the same people were affected by those digital and health inequalities really was the starting point of our research doing eHealth Right. And the aim of this research was to increase the health potential of people with a low socioeconomic position and to prevent health inequities from widening further by addressing the growing digital gap regarding the eHealth services. A very large aim, and I think we can contribute to this aim, but there were more work should be done. And as I said, we combine system thinking with participatory action research to do this project. And I won't go into all the details, but what I would like to share is two more um, dominant perspectives which should be shifted in order to make sure that we can design a more inclusive digitized healthcare system. And the first one is the shift that is needed, the shift on efficiency. And this shift is based on an article which we wrote together with the PhD student Ibrahim Lukili. And it is about the implementation of self-check-in kiosk in a hospital. And the self-check-in kiosks are implemented to reduce cost, to increase the patient experience, but also to increase information transparency. And our question was really, okay, but for who does this increase the patient experience, for who not? And in which situation this machine can help, in which situation it cannot. And one of the most interesting findings was that, well, the goal is to reduce the work, of course, of doctor's assistants. It increases the invisible work for some patients. many patients were uncertain and really needed to ask questions whether they did it right or wrong. And this was mostly caused by the fact that people are not entering an hospital because they are going to do something nice. They are being there because they have an appointment with a doctor, getting a second opinion, or getting a treatment. So people are entering a hospital already stressed, and the machine can add extra stress. So there were a lot of people asking us for help during the participatory observations. And also, it increases work for people who needed to search for people who could help them out. And this example of the researcher Ibrahim was really interesting to see, because two women with a child were walking around and searching, and they had a conversation in Arabic. And since Ibrahim also speaks Arabic, he asked them if he could help them, and they explained that they really didn't know how to use the machine, and there was no one to help them. And those women were really stressed out because they needed to go to the appointment, but they didn't know how. And here you see that it increases work for those patients because they were a little bit, they didn't trust their own skills. But it is not only about trusting your own digital skills. We also saw it increase work for patients who were sitting, for example, in a wheelchair, who couldn't reach to the machine, or people who had less eyesight and they couldn't use the machine. So it was also the physical, the typical patient. Um, um, yeah, patients have disabilities, so the machine was not adapted to all those different kinds of disabilities, physical disabilities. And it was also interesting to see that it increases the invisible work of staff. For example, doctor's assistants told us that a lot of patients don't find the right waiting room, and that the doctors keep walking back and forth for searching for patient. And she said herself, yeah, that's also not really efficient. And also, an hospital administrator was really frustrated because his staff was so caring, and then patients frequently seek help from healthcare workers because they didn't understand the machine, and they receive assistance because healthcare workers are in itself really caring. But he said that it takes up a disproportionate amount of time and only worsen the pressure on the healthcare system. So it was not really efficient. Yeah, there were less people at the desk, but the staff that was there had more work to do. So I think that we need to shift our perspectives on efficiency. So what makes technology good or bad cannot only be understood in terms of organizational efficiency. We really need to study a technology in practice, and we should evaluate the normative unintended consequences of medical technologies, and then especially for those patients in more vulnerable circumstances. So to really understand what's happening in practice if technology is implemented. So we should question more often for whom and in what situation is this innovation efficient. And then not only the efficiency of the hospital, but also the efficiency of patients. For patients, sorry. And a second shift in perspective, which I think is really interesting and is needed, is also a shift in the work we do as EOF researchers. And this is based on a scientific review, and it was led by Jessica Kutzer. And the aim was to explore how EF use amongst people with a distance on the world is framed within the current system, and particular from perspective of researchers. And it was a qualitative meta review. And for your context, it was interesting to see that most of the reviews, which were 29 reviews included, and most of the reviews were written from scholars who had a background in health informatics or medical technologies or medicine, and only a few in social sciences. So there was interesting context information, I think. And what we learned from this meta review is that e-health is often presented as a simple fix for a really complex problem. It's presented as it can increase access to healthcare for people. It can reduce healthcare costs. It can improve patient outcomes. It can increase um, the efficiency. And by framing e-health as a simple solution, there's really a substantial risk of overlooking the inequities that it can create by more digitally marginalized groups. So people tend to overlook those groups in the reviews, but also in more empirical studies, because then in that case, people with a distance from the online world are described as harder to reach, or inclusion criteria like speaking the language of the host country or having access to a phone are already exclusion criteria. So I think it's important that we as a research community, that we should not present e-health as a simple fix, but also questioning the inequities that it can create. And a second learning, which I think is really interesting from this systematic review, is that barriers to e-health are often framed as individualistic issues, like lack of interest, low self-efficacy, lack of social support, lack of access, what are not and what are way less more systemically framed barriers, and the ones who are systematically framed are often also harder to tackle. So if a policymaker would read uh, a review like this, I can definitely understand that the focus is on those individual frame barriers and try to find solution, because they are more tangible, and they're the solutions that can be think of are more easy to implement than those for the more systemically framed barriers. And I think what is needed from us, that we should avoid really the focus on those individual barriers, but that we also could reframe them as more systemically framed barriers. For example, digital skills could also be reframed as technology developed without a diverse competencies in mind, or lack of trust could also be reframed in lack of transparency. So I think we need to challenge ourselves to really frame barriers to e-health not as individual problems, but as system problems. Then I would like to end with this slide, and I think what my main message was in this presentation, that the single mind focus on the promises of technology and the individual skills, with too little attention to the system in which e-health is developed and implemented, um, should be changed. So we really should broaden on our focus. And it's also really interesting to see that there are a lot of opportunities, because e-health can also help to reduce health inequalities. So it's a challenge that we can take up, how we can design a digital society which is more inclusive. And there is a role for technology developers, policymakers, doctors, healthcare organizations, community organizations, but also to be critical on our own role. What is our own role in this, and how can we contribute to a more inclusive digitized health system? We have approximately 1.5 years to go in this project. So doing eHealth right, a positive game changer for people with a low socioeconomic position, and it's a collaborative research program with the Amsterdam Medical Center and the Vrije Universiteit. And if you want to have more information, or you want to collaborate, please send me an email or go to our website.